and sterol hydroxylase has been reported by Kali and Russell long time ago. So we have now biomolecular diagnosis that has been made by cholesterol levels, sterols, sterol concentration, impairment of bile acid synthesis, increased level of bile alcohols, changes in blood-brain barrier, and CTX mutation. We have investigated a lot of patients in Italy, and we have also investigated patients from other parts of the world with clinical findings that are cataract, tendonxantomas, diarrhea, osteoporosis, and the other classical phenotypic presentation. But we have seen also cases with absence of cataracts or absence of xanthomas that may quite difficult the diagnosis. And we have also another very interesting sign that is that is present classically in the majority of patients, and after bronchoalveolar lavage by fibroscopy, we have evaluated microscopic examination in several cases with presence of macrophage with cytoplasmic lipid inclusion. You see here the findings of this macrophage that store lipids, and this improve after chenodeoxycholic acid. We have seen several cases with Parkinsonian syndrome that is very atypical. They are considered not very well responding Parkinson disease, usually by general doctors, and you see here the classical presentation, Parkinsonian patient that will improve after chenodeoxycholic acid therapy. This is very important. Here you see another Parkinsonian patients with alteration in basal nuclei, and also recently has been reported new features of CTX only with blepharospasm that enlarge the clinical presentation of extrapyramidal changes. The other problem is spasticity. We discussed before. Ludo van Bokert reported a spinal form of CTX. There are cases in which the presentation is mainly characterized by spinal by spasticity, and this we have investigated in a series of patients associated with polyneuropathy, and we have also investigated the neurophysiological parameters that will follow during the chenodeoxycholic acid therapy. The problem of mutation, we have a lot of mutation in the gene, but will be discussed later. We try to have some phenotype-genotype correlation without any possibility. We try to correlate cataract with or without cataract, but our numbers were too few to have such phenotype-genotype correlation. And there is some problem of therapy that will be discussed later, and there are many open problem. Now we are improvement in many parameters, but we have also a lot of things to do. We need a pre-symptomatic detection of this treatable condition, and we have several regions in which such mutations are present. For instance, in Italy is Sardinia, one, another is Sicily, and we discussed this morning that it is possible that this gene comes from the Africa, but we need to improve our data with an European link. And this is one of the last my slides that is like a new necessity of approach to an early diagnosis. This is a baby of 8 years old that at 2 months were affected by severe hyperbilirubinemia and jaundice. Liver biopsy was characterized by progressive familial cholestanosis, and it was present increased bile acid and cholesterol. It was present and a deletion from exon 7-9 of CTX gene was treated by chenodeoxycholic acid with normalization of cholesterol and liver parameters, and now at the age of 8 she's normal, brain is normal, she has no cataract, no diarrhea of course, and similar data has been reported by other people, by Barkham, the same mutation in a very severe fatal cholestasis in infancy, and the baby died because the treatment was not as the diagnosis was not done, and there is now similar cases that has been treated by cholic acid therapy by French people. So we need that an early diagnosis is very important for very severe hepatic findings. But we have also other new data. For instance, this gene that may be a susceptibility for sporadic for sporadic amyotrophic lateral sclerosis phenotype, and this open a problem, a link of these abnormalities with neurodegeneration that is useful to investigate. Also the presence in carrier, this is a large pedigree in which we see that carrier have some minor clinical findings that is very important to investigate. For instance, also this gene was correlated with coronary artery disease in heterozygous situation, and could be one possibility to have a network that will be necessary to have research facilities in larger number of patients, harmonization of therapy, research on new treatment facilities for patient support activity, and to give an answer to the open questions that are still present: early therapy, responder and non-responder subjects, difference in male, female affected patient with this disease, the cause of very severe psychiatric symptoms and linked with neuropharmacology and some receptors, heterogeneity in clinical progression, genotype, phenotype, and minor signs in carriers. And so I think this is a sentence that I love very much, and that is especially dedicated to this structure. I think that nature, this is a very old sentence of 1647 by William Harvey, nature is nowhere accustomed more open to display here sacred mysteries that in cases where she shows traces after walking apart from the better path. Nor is there any better way to advance the proper practice of medicine than to give our minds to the discoveries of the usual law of nature by careful investigation of cause of rare form of disease. For it has been found in almost all things that what they contain of useful or applicable is heartily perceived under we are deprived of them, or they become deranged in some way. And this is the reason that I think that the study of rare disease is not a butterfly collection, but an entry for understanding the common condition of the physiology of the body and of the brain and nervous system. And this is our group that I thank very much for the work that has been done in this field. Thank you very much.
Thank you so much, Dr. Federico, for this wonderful introduction. I think you already made some of the critical points that we're going to be discussing through the whole day. We're going to have a discussion later on, so we'll leave questions for then. Now we are also lucky to have Dr. A.VERRIPS, so you can see how we have had so much luck to have the most relevant people in Europe, I would say, on this disease, those from whom we can learn most. And thank you so much again to you, Dr. A.VERRIPS. He comes from Nijmegen, I can never pronounce that correctly. And as you know, they have also been studying this disease for so many years that they will share this now for us and their thoughts. Thank you. Are you ready with it? Let me see. So in the meantime, maybe, yes, I couldn't agree more with the main points, Dr. Federico, that, you are already sort of opened for, so we can start thinking about, first, this is really a systemic disease. Second, how much we have advanced since the early days, but how much we still don't know. And the importance of collecting data, which seems like a tedious, don't know where we're going with the data, but it's not. It's so key, it's so relevant. Though for patients and family, sometimes when we talk about registries and just checking data on individuals, it might sometimes seem that it doesn't take us to anywhere practical, but it does, because it helps understand where are the differences. Why is this patient doing well and this isn't? Those are studies that will give us clues to where to go. So I think that's a very important point, that we will have time to discuss all these things. Okay, thank you so much.
Thank you very much. Thank you for the invitation here to come here to Spain. Like Professor Federico, I was very impressed by your great organization here for patients with rare diseases. Thank you, and I would like to start with my presentation. It's divided in 4 parts. I would like to talk with you about the CTX history in the Netherlands, and then I say something about pediatric cases, something about therapy and clinical follow-up, and then the literature. And in the Netherlands, the CTX history started in 1977 with the first description of 3 Dutch patients from Amsterdam, and it's further have been investigated by the group in Groningen, Koopmans, Waterreus, you had it already on your slide. And then in 1991, Professor Hans Kruisberg, who was an ophthalmologist in the University in Nijmegen, described with Ron Wevers and Jules Tolboom children with CTX, and they described 2 index patients and discovered 3 affected SIPs. And nowadays, up to now, we have 72 CTX patients in the Netherlands. We have seen them out of 43 families. 20 have deceased, particularly of non-CTX related diseases like colon cancer and so on. And we have clinical data and genetical data from 26 CTX patients out of 80 families from abroad. Well, I think we discussed it already. The CTX prevalence is higher, I think, than we know. Woolwich published a paper in 2005 in the Archives of Neurology, where he estimates that the prevalence could be one patient in 50,000 people. And that means that in the Netherlands there must be more than 300 patients. I think still it's an underdiagnosed or misdiagnosed disease. So let's go to the children. We now have 19 children out of 11 families in the Netherlands. And age at diagnosis varied between a few days to 20 years, and 20 years is sibling from an affected index patient. Mean age at diagnosis is 10 years, and the mean follow-up now is 12 years, with a range of 2 to 24 years. And in pediatric CTX, the clinical hallmarks are intractable diarrhea, bilateral cataracts, and neurological symptoms and signs, which develop already in the first decade and are mainly mental retardation in the first decade. Well, my daughter translated this cartoon of Fokker and Sucker, and I think that's the most important sign and symptom at the pediatric age group. I think there are 3 disease stages in CTX patients. So the first disease stage is in the first decade, with bilateral cataracts and diarrhea and the subtle development of neurological symptoms and signs. And then in the second and third decade, the neurological symptoms and signs are more severe, and xanthomas may develop. And then after 30 years, no, it's a mistake, it's Dutch, years, there are severe neurological symptoms and signs. And we try to make to investigate if there's a genotype-phenotype correlation in CTX. And at the moment, we could identify 125 patients from our group and the literature. We could identify 79 homozygous patients out of 45 families with 23 mutations, and we could establish genotype-phenotype correlation. And you know already the intrafamiliar phenotype has a great variability. Well, perhaps I think that maybe a new phenotype in CTX that is called hepatitis of infancy. Peter Clayton from London has published it for the first time in 1995, and that patient has been diagnosed several years later as being a CTX patient. And Professor Federico mentioned it already, there are more groups that identify very young patients with hepatitis which can be fatal. And this is a summary of the first patient by Peter Clayton. It was the 4th child of non-consanguineous parents. The first child had deceased because of a prolonged jaundice, liver dysfunction. And the 3rd child was a stillbirth, and this 4th child had a jaundice and a hepatomegaly at the age of 7 days, and laboratory investigation showed a conjugated hyperbilirubinemia, difficult word, with raised transaminases and alkaline phosphatase with normal gamma GT. And the liver biopsy, which was done, showed a giant cell hepatitis, and in the metabolic investigation there was a tetrol found in the plasma and urine excretion of one of the bile alcohols. And he was treated with cholic acid, and normalization of liver function resulted, and a new liver biopsy at the age of 140 years showed still a giant cell hepatitis. And at the age of 11 years, because the patient was monitored, and at the age of 11 years, no CDCA cholic acid in plasma was found. It was undetectable, and bile acid precursors in serum showed a more CTX profile with an elevated cholesterol level, and also the urine bile alcohol analysis showed a more CTX profile, and mutation analysis confirmed that this patient was actually a CTX patient. Well, we then reviewed in our database of, at that moment, 76 CTX patients, whether there were more patients who were jaundiced, who had a prolonged jaundice in early life. And in 9 patients we had reliable neonatal data, and we found that in 6 of those 9 there was a prolonged neonatal jaundice. And we looked also if there is an excess of fetal deaths among siblings of the affected individuals, and we found 4 out of this 9 that have fetal deaths. Von Beer reported in 2005 a first child of consanguineous parents with an intrauterine growth retardation and prolonged neonatal jaundice, which had at the age of 6 weeks also a hyperbilirubinemia with liver function disorder, and the liver biopsy showed a giant cell hepatitis. That must be at 6 weeks. I had the wrong number, 6 weeks. And that patient died, and there was a matter of debate whether there was a CMV infection involved as well. And this patient had been treated with ursodeoxycholic acid, but at the age of 3 months there was severe liver failure, and cholic acid was started, but the boy died at the age of 4 months, and mutation analysis confirmed the mutation of the CYP27 gene. Well, these are the data from Amsterdam, and it's submitted for publication, it's still unpublished, and it concerns an 8-day-old girl with feeding difficulties, lethargy and convulsions, which was referred to the academic hospital in Amsterdam. And eventually a viral infection was diagnosed, but in the metabolic workup for screening of inborn errors of metabolism because of the convulsions and feeding difficulties, accidentally elevated serum cholesterol was found, and very low levels of CDCA and cholic acid. And in urine, bile alcohols were found. So this patient was suspected to have CTX, and that was confirmed with mutation analysis. And she started at the age of 8 weeks with CDCA supplementation in a dose of 50 milligrams per kilograms daily. And 6 weeks after the initiation of this therapy, she jaundiced, had pruritus and a mild hepatomegaly with disturbed liver functions, elevation of bilirubin transaminases and alkaline phosphatase. So after many discussions, many phone calls, we decided to stop the CDCA supplementation after 8 weeks of therapy, and that results in a normalization of the liver size within 1 month and normalization of liver enzyme values within 3 months. And after 2 months we restarted the CDCA therapy, but in much more lower dose, 5 milligrams per kilograms daily. And this resulted in a further decrease in plasma cholesterol, and the liver function remains normal. And that's been graphically displayed here. I don't know which one I will point, but you see here one of the transaminase, the SGPT, and there's a race with disturbance of liver functions. This is the period of treatment with high dose CDCA during 8 weeks. This is the stop of CDCA, and this is the restart with 5 milligrams per kilogram daily. And it is shown here that liver function normalizes after the low dose CDCA is restarted. And here you see the cholesterol levels. First, after the start of therapy, there's a decline in the serum cholesterol level, and then it rises again. And I don't have a definite explanation for it. Perhaps it's liver cell necrosis and the release of cholesterol in the serum. And then it falls again, and after the start of the relatively low dose CDCA, it remains low and below the upper level of normal. And clinically, she does fine. She's almost 3 years now and has no symptoms or signs at all. So I think that hepatitis of infancy can be part of the CTX phenotype. Probably, but I'm not sure, it can be amplified by high dose of CDCA therapy. It may be fatal, but we're not sure, because in the patient of Van Beer, other causes may have interfered with the fatal result. Hepatitis of infancy might disappear during follow-up, as we have seen in patients in the literature, and I think that 5 milligrams per kilogram daily CDCA might be safe and effective. Well, could we identify more patients? And that's your topic, Dr. Kocho, this morning. And the one who published it was Andrea de Barber in Boston, and she published that investigation of 2 dried blood spots can identify precursors of cholesterol, 7-alpha, 12-alpha dehydroxy 4-cholesterol 3-1. It was 10 times elevated compared to normal, and it was more a marker than the cholesterol, because cholesterol determination in the dry blood spot was only 2 times higher than normal, and there could be an overlap. But this method still needs to be validated. And I want to shift now to the therapy and the treatment follow-up. In 2009 we decided to look what the results are of the long-term CDCA therapy in 32 patients at that moment, when we could retrieve as much as possible data. And we made 2 groups. 21 year was the division. 13 patients started CDCA therapy before that age, and 19 started it after 21 years. Treatment duration varied between 8 months and 27 years, with a mean treatment period of 11.4 years. And the 13 patients here, 9 males and 4 females, with a mean treatment duration of 9.4 years. And we saw after start of treatment that diarrhea decreases from 13 to 3 patients. All patients had cataract extractions. And we saw also improvement in the neurological signs, particularly the pyramidal, there's low numbers, but pyramidal signs disappeared in 2 patients, and also did the cerebellar signs. Intelligence didn't improve, unfortunately. Epilepsy